Okay, here we go. This is Radiology, CPT 2017. Starts with your table of contents. So we have the diagnostic radiology, we have diagnostic ultrasound, radiological guidance, regardless, there's three kinds, your mammograms, your radiation oncology, and then your nuke med. So that's what we're going to go through. A little bit of um, uh, instruction guidelines. Sorry, I'll get the word in a minute. Okay, so just like several of the other sections of the CPT, radiology does start at the top of the body. So your head and neck is first. Within each of these organ or body systems, you start with your radiological or radiologic, I'll say it in a minute, radiologic exams. Then you go into your CTs, your MRIs, and your MRAs. MRIs is imaging, MRA is angiographies. So you'll see this throughout. You'll see all my arrows and stuff. All I've done is pick up my radiologic exams, and then I start with my computed tomographies for my CTs or CAT scans, MRIs, and MRAs. Chest, same thing. You've got your x-rays, your CAT scans, your MRIs, your spine and pelvis, x-rays, your CTs start down here, MRIs. There's a few extra things within your spine and pelvis because there is an option to do a computed tomographic angiography of the pelvis. So it's a little different. They also have some myelographies. Myelo meaning brain or spinal cord. Since this is spinal cord, they have some myelographies in here. They have some epidurographies, some discographies. So a few different pictures that can be taken of some of the specific layers of the spine and that spinal cord. Getting into upper extremities, you have your x-rays, your CAT scans, your MRIs, MRAs. See, this is just a great way to organize your thoughts. So when you come to radiology, are you looking for x-rays? If you are, what's your body part? Go to your body part, and then it at least really narrows the playing field. Lower extremities, your abdomen. Now with abdomen, these can, and I have a note here, they can include KUBs, kidney, ureter, and bladder. So kind of keep that in mind. You have your, oh, another thing to keep in mind is with and without contrast, the dye. Gastrointestinal tract, urinary tract, these are all urographies. Notes that you need to put in here. Bundled into these codes is the catheter placement in order to perform the urography, but the injection of dye would be coded extra. So it would be coded extra. Then you have a few GYN and OB, just a few. The real OB, pregnant ultrasounds and stuff are further in this section. These are a little bit different. These are different MRIs, different imaging things, not ultrasounds. We have a few of the heart. Again, MRIs, CAT scans of the heart. Then we go into our vascular procedures. So we know vascular includes both arteries and veins. So this first section is our aorta and our arteries. Keep in mind our aorta is very long, so you have several different parts of it. You have your thoracic part. You have your abdominal part. Then we get into angiographies of the extremities. This is still for arteries, but this is more in extremities and other parts of the body, pulmonary, that kind of thing. Then we're into our veins and lymphatics. Here's a lymph angiography. I always try to add the lympho, but it isn't. Then we have one for a spleen. Then we have venographies. These are specific to veins, taking pictures of veins. Lots of pictures in here that would be good for writing in if you needed to. Then we have different transcatheter procedures. Now, these codes in here is the radiological components to them. You probably have already seen several of these codes because they're the radiology part of the actual procedure. What's included in them is listed here, good guidelines to what's included. Other procedures, this is your fluoroscopy for your docs that are in here, kind of a little bit of a catch-all, some different CAT scans, limited, MRIs that are limited. Then we're into diagnostic ultrasound. This was diagnostic radiology, now we're into diagnostic ultrasound. Good definitions here of the different lingos that you will see on your different ultrasound reports. Again, it starts with the top of the body, so your head and neck, chest, abdomen, spinal cord. There's only one code, not too hard. Then we're into the obstetrical ultrasounds. So these are the pregnancy ultrasounds. I very much go through and underline what my trimester is, how many weeks, is this transabdominal approach or is it a transvaginal approach? Is it for the fetus and the mom, just the fetus, single fetus, dual fetus? Is it for fetal and maternal evaluation plus detailed fetal anatomic examination? You know, I kind of want my eyes to see stuff in here because these different ultrasounds get a little clustered in my mind. And like this 76816 right in the middle, it has follow-up. So there are folks that will miss that. So I obviously have missed it. That's why it's underlined now. Okay, extremity ultrasounds. Extremity ultrasounds, these are non-vascular. Here's ultrasonic guidance or ultrasound guidance. We've already seen some of these when we were in cardiovascular and we did the central venous access codes. We used some of these ultrasound guidance codes. Here's your fluoroscopic guidance and here's your CT guidance. So on these 2 pages are the 3 ways that you can have guidance. Oh, 4 ways because there's your MRI guidance. On your mammograms, I want to talk about 2 different lingo terminology. When you see screening mammogram, screening means the patient hasn't ever had any problems with their breasts. They've not had lumps or pain or anything like that. They're just going in for their yearly or every 5 years, whatever mammogram. There's no problem. No big family history, nothing. They're just being screened. Chances are they're not looking to find anything. There's no problems, so there's no anticipation that they would find anything. Diagnostic mammograms are very different. That you either have symptoms and they're diagnosing it. Maybe you have a very, very, very strong, well, even with a strong family history, you would still need some type of medical necessity or symptom in order to get a diagnostic mammogram. But your diagnostic mammograms they are pretty sure they're going to find something because you have symptoms, and so they're going to diagnose what the problem is. Whereas screening, there's no indication to have it. It's just simply screening, simply routine. Okay, radiation oncology. This is the section where the physician plans, simulates, and calculates radiation treatment for the patient. These 3 sections, planning, simulation, and calculation, are all done by the physician. Nobody else does them but the physician. They do have some good guidelines on what simple, intermediate, and complex is. What the planning is the oncologist takes into account the patient's age, what the cancer is, where it's located, and says, well, I think this is what we need. This is what we're going to need to do. Once he writes the plan, then he's going to simulate it in some type of virtual atmosphere, plugging in all of the patient's demographics, tumor specifics, and all of that to see if the computer agrees that this plan is simulated correct and will work. The right angles, the right whatever. Once it's simulated, then the calculation or the dosage of radiation dosimetry is decided. And then is there a need for different treatment devices, blocks and stuff, to block out other organs, you know, so you don't cause damage to the surrounding areas. And is there any special therapy? Is there brachytherapy? Brachytherapy is when you instill medication, radioactive medication seeds, whatever it is, into body organs or body cavities. So you've got your planning, you've got your simulation, you've got your calculation. That's all done by the doctor. This section here called radiation treatment delivery, this is for the facility only. It's the technical side of actually dispersing or delivering the radiation. So we would not typically do anything with that because we're physician based. Then we have radiation treatment management. Radiation treatment management, this is the supervision of the actual time that the patient has shown up for their radiation therapy when it's being delivered. Technical side, this is the professional side. So you're going to need a 26 modifier here. These radiation treatments are billed on a weekly basis based on however many treatments or fractions that the patient receives. There is some information here, and we need to go over correct code usage. You have the last part of this paragraph. First, I'm going to talk about the codes, then I'm going to explain the codes and what this particular guideline means, because you'll see this on the board and it's confusing at best. So, okay, basic. 77427, this is treatment management, 5 treatments or 5 fractions a week. So let's say our scenario, patient's receiving 5 fractions a week for 4 weeks. So you would bill 77427 first week, 77427 week 2, 77427 week 3, 77427 week 4. Okay? Simple, done. Patient's done. Same patient, the very last week of treatment. Week 1 they had 5, week 2 they had 5, week 3 they had 5, but week 4 they had 6 or they had 7 treatments. It's the end of their course, but they had 6 or 7, 1 or 2 more than their 5. This is telling you 1 or 2 fractions beyond a multiple of 5 at the end of the course of treatment are not reported separately. So on that week 4, if the patient has 5, 6, or 7 treatments, you do not code extra. Now, let's say that 4th week the patient had 8 or 9 treatments. They had 8 or 9, not 5, 6, 7. They had 8 or 9. This tells me code 77427 is also reported if there are 3 or 4 fractions beyond a multiple of 5 at the end of a course treatment. So let's say week 1 they had 5, so that's 77427. Week 2, 5, 77427. Week 3, 5 treatments, 77427. The 4th and final week, they had 9 treatments or 8 treatments, 8 or 9. You would code 77427 for the 5 treatments and 77427 for those additional 3 or 4. That is based on this guideline. So the extra 1 or 2 at the end, don't code extra. Extra 3 or 4, you do. That's it in a nutshell. Now, what becomes very confusing? Let's look at code 77431. 77431. This is telling you if the entire course of treatment, please listen to this, the entire course of treatment is only 1 or 2 fractions. The whole thing. They're going to give, week 1, they're going to give radiation once. Week 2, they're going to give radiation once. Maybe week 1, they're going to give it once, and week 3, they're going to give it once. Or maybe they're going to give it once a month for 2 months. So the course of treatment is 8 weeks long, and they're giving it at the first of each month. So the entire treatment course is 1 or 2 treatments. Then you code only 77431. You listen to me. You cannot code 77431 for those extra 1 or 2 treatments on the last week of your 77427. You cannot. And this actually says that you cannot do it because everybody wants to do it. So really pay attention. And that's it. Once you get that, you've got it all. Here is a table, kind of tells you what's technical and what's professional. Clinical brachytherapy, I already kind of talked about that. That's where they instill into body organs or cavities some type of radiation source, seeds, whatever it is. Then we're into nuke med. This is the last section, diagnostic nuke med, and it's divided by organ systems. So you've got your endocrine system, you've got your blood and lymphatic system, your GI system, musculoskeletal, cardiovascular, kind of goes on and on. So just in your mind, remember, nuke med is at the end of radiology. Respiratory, nervous, genitourinary. Other procedures is a little bit of a catch-all. And then you have your radiopharmaceutical therapy, your therapeutic type of procedures, which are radiologically tied. Different intracavitary, just different. These are very specific. You'll read in there. You'll see different IV administrations. It depends on how they're therapeutically administering it as to which code you're going to pick. And that is it for radiology.